If we see the heart failure with reduced ejection fraction, there is a problem in the heart and then other organs are affected. If we go by the definition, it's inability to sustain the adequate metabolism of the other organs. While in heart failure with preserved ejection fraction, is the problem somewhere else and it comes to the heart. And that's why there are metabolic diseases that brings a lot of metabolic stress, aging, that leads to the cardiac remodeling, then fibrosis, that is the ventricular stiffening, and in addition there are OSAs, obesities or sedentary lifestyle, and that combinedly leads to the loss of functional myocardium or improper functioning of the viable myocardium, and that leads to the heart failure with preserved ejection fraction. So that's why even if the ejection fraction is preserved, the diastolic function is gone wrong, and that's why we say it's a lusiotropic dysfunction of heart. If we see the mortality analysis of HFpEF, its non-cardiac also tops the list. If we compare the graph of heart failure with reduced ejection fraction, the non-cardiovascular death amounts only to the 36%. Majority are coronary or heart-related deaths, while in HFpEF, the majority are non-cardiovascular deaths or other than cardiovascular deaths. So this brings out a lot of heterogeneity. If we see the mode of death in I-PRESERVE trial, just for the example, see the majority of deaths are not directly cardiovascular deaths, and that is what the HFpEF becomes a difficult animal to treat or to analyze also. So far there are two good trials with HFpEF. One is a PARAMOUNT trial which showed improvement in variety of softer domains with ARNI, or we can say a lot of surrogate markers were there which showed improvement. So it's very difficult to prove a direct mortality benefit in HFpEF, that is heart failure with preserved ejection fraction, if we saw a majority were non-cardiac. That's why we have to rely on the surrogate markers. That is, PARAMOUNT trial clearly showed improvements in NT-proBNP parameters, improvement in left atrial size or LA volumes were reduced. Patient did say that there is improvement in the NYHA class. So PARAMOUNT did show some benefit of ARNI in heart failure with preserved ejection fraction. Then came the important trial, that is PARAGON-HF. That showed, okay, cardiovascular death, not much of the benefits, but if we see on the left side, there is definite reduction in heart failure hospitalizations in the valsartan arm versus sacubitril valsartan arm. The statistical significance was not achieved, but the numerical significance was definitely there. So that is how the PARAGON-HF brought out 2-3 very important and interesting findings. That those heart failure patients who are recently hospitalized, they will get the maximum benefit of ARNI as compared to a stabilized patients and now not hospitalized. That's why if we see a graph on the left side, it shows heart failure with 30-day hospitalization versus 30 to 90 days versus more than 6 months, 3 months to 6 months, more than 6 months, and patient never hospitalized for heart failure. If we see the progressive quantum of benefit goes down. So patient who has never got hospitalized for heart failure but has a heart failure with preserved ejection fraction probably may not get an impressive benefit. While those who have already got hospitalization required, they are bound to get benefit because they are more sicker population. Similarly, the good benefits were shown across the EF. If we see the total HF hospitalizations and cardiovascular death by LVEF tertiles, ejection fraction less than 25%, okay, it favors sacubitril valsartan, but the benefit is less as compared to those who are between 25 to 30 or 30 to 33 or up to 40% good benefit. Again, once it goes into the preserved arm, that is beyond 36 to 50 and beyond 50, there is lesser benefit of sacubitril valsartan because they are with HFpEF. Beyond 60%, there is no benefit of ARNI. Means it won't change the mortality statistics because they are already a fitter population. See, less than 25 because they are too sick to survive, so mortality is bound to be higher. Beyond 60%, they are already good EF, so that's why lesser benefit. But in between, that is heart failure with reduced ejection fraction and mid-range heart failure, these are the candidates which gets a good benefit of ARNI, and that is the conclusion what we should get out of these trials.